In 1861, Thomas Graham classified substances as crystalloids and colloids based on their ability to diffuse through a parchment membrane. Crystalloids can diffuse through this membrane easily, while the colloids largely cannot diffuse through this membrane. In this video, we will be talking about the crystalloids like the normal saline, the ringer's lactate, and the normal saline with dextrose solutions, etc. Now, coming back to the history, in 1880, a British physician, Sidney Ringer, introduced a sodium chloride solution that also has calcium and potassium. This is known as Ringer's solution. Now, 50 years after the introduction of Ringer's solution, American pediatrician Alexis Hartman added sodium lactate to this Ringer's solution. This came to be known as Hartman solution, now also as Ringer's lactate. This lactate in the Ringer's lactate provide a buffer for treatment of metabolic acidosis. And because of concerns that large volume infusion of Ringer's lactate may increase lactate levels in persons with liver disease, lactate was replaced by acetate, and this is known as Ringer's acetate. So theoretically, in patients suffering from liver disease, if we have to give the Ringer's solutions, then we should choose the Ringer's acetate Ra instead of the Ringer's lactate Rl. Now, the second point I want to make here is that, contrary to the name, normal saline is not normal. Because if we look at the composition of various crystalloids and compare that with the plasma, as you can see here in the chart, the blood plasma has a sodium concentration of 140 milliequivalents per liter, a chloride of 103, potassium 4, calcium 4, magnesium 2, and bicarbonate buffer of 25. That gives us the osmolality of 290 and a normal pH of 7.4. If we look at the normal saline, the sodium content is much higher than the plasma, that is 154. The chloride content is also higher, 154, which gives us a low pH, 5.7, and a higher osmolality, that is 308. So normal saline is not perfectly isotonic, and it is slightly hypertonic. So in normal saline, the sodium content is high, the chloride content is high, the pH is low, and the osmolality is also high. So nothing is normal in normal saline. Now, if you look at the composition of Ringer's lactate, Rl, the sodium content is 130, which is more or less comparable to the plasma content. The chloride content is 109, potassium 4, calcium 3, and then a buffer of lactate 28, which gives us a pH of 6.5 and osmolality of 273, which is again very close to that of the plasma, that is 290. So Rinker's lactate is more normal than the normal saline. One more point is that the SID, that is strong ion difference of plasma, is 37, which gives us a pH of 7.4. Now, what is SID? The strong ion difference is the difference between readily dissolved cations and anions in the extracellular fluid, which basically means the difference between sodium and chloride. In the plasma, the normal sodium content is about 140 milliequivalents per liter, and that of the chloride is about 103 milliequivalents per liter, which gives us a SID of 37. Now, if we look at the normal saline, the SID is 0 because the sodium and chloride contents are equal, 154 milliequivalents per liter each. That is why the pH of normal saline is much lower than that of the plasma. Rinker's lactate, on the other hand, give us a SID of around 28, which is pretty much close to that of the plasma. Now, coming to the advantages and disadvantages of crystalloids, based on what we've already discussed. The disadvantages of normal saline include: number 1, interstitial edema. Whenever we infuse intravenous fluid into somebody's vein, 75% of the volume goes into the interstitium and only about 25% stays inside the vasculature. That is why, theoretically, the colloids like albumin solution and the dextran solutions are supposed to be more effective in intravascular volume expanding. Now, 75% of the normal saline that we give will stay in the interstitium, and since the sodium content of normal saline is higher than that of the plasma, water will be drawn from the cells into the interstitium. That is why interstitial edema is seen. Another mechanism is due to increased sodium load, the tonicity of interstitial fluid is increased, and this promotes sodium retention by suppressing the RAS, that is renin angiotensin aldosterone system. The second disadvantage of normal saline is decreased renal perfusion, which presumably is a result of chloride-mediated renal vasoconstriction. Remember, the chloride content of normal saline is again high, 154 milliequivalents per liter, much higher than that of the plasma. The third disadvantage, and a very significant disadvantage of normal saline, is the effect on acid-base balance. If normal saline is infused at the rate of 30 ml per kg per hour for 2 hours, it can reduce the blood pH from 7.41 to 7.28. This is known as hyperchloremic metabolic acidosis. Another disadvantage of normal saline is that the plasma bicarbonate level decreases as the chloride concentration increases. Last but not the least is the dilution of PRBC. However, one must understand that these effects probably will happen only if a large quantity of normal saline is infused over a short period. Now, there are some clear indications or advantages of normal saline, such as in case of hyponatremia and hypochloremia, because of the higher content of sodium and the chloride, normal saline should be used. And in brain injury, the calcium contained in Ringer's lactate may increase the neuronal injury. For fear of that, the normal saline can be given. Now, coming to the Ringer's solutions like plain Ringer's solution, the Ringer's lactate, or the Ringer's acetate, they are considered relatively safe, and they are the crystalloid of choice for volume replacement, and there is no significant effect on acid-base balance. However, blood should not be given through the same drip set where Ringer's solution has been run, because the ionized calcium in Ringer's solutions can bind to the citrated anticoagulant in stored RBCs, and this can promote clot formation. And secondly, the lactate content in Ringer's lactate creates concern about the risk of spurious hyperlactatemia with large volume infusions of the fluid. However, lactated Ringer's infusions are unlikely to have a considerable impact on serum lactate levels unless large volumes are infused in patients with virtually no capacity for clearing lactate from the bloodstream. For a D5W, that is 5% dextrose solution, the aided dextrose brings the osmolality close to that of plasma. However, since the dextrose is taken up by cells and metabolized, this osmolality effect rapidly wanes, and the added water then moves into cells. Because without dextrose, the solution is more or less just water, and this is hypotonic, so it will move into the cells. The infusion of 1 liter of D5W results in an increase in extracellular fluid of about 350 ml, which means the remaining 650 ml has moved intracellularly. Therefore, the predominant effect of D5W is cellular swelling. An effect opposite to that can occur when dextrose is added to 0.9% sodium chloride to make DNS. When 50 grams of dextrose is added to make D5 normal saline, the osmolality of the fluid increases to 560 milliosmol per liter, which is almost twice the normal osmolality of the extracellular fluid. If glucose utilization is impaired, as is commonly seen in critically ill patients, large volume infusion of DNS can result in cellular dehydration. In healthy subjects, only 5% of the infused glucose load will result in lactate formation, but in critically ill patients with tissue hypoperfusion, as much as 85% of glucose metabolism is diverted to lactate production. That is all for crystalloids. Watch out for the colloids. Thank you for watching. Please subscribe.